When I did cardiac physiology, I said to him, I swear on my life, I will never be a cardiologist. This is terrible. And look at me now.
Dr. Renee, I don't know what to call you, Rodriguez or Paro. How are you, my friend?
Fine. Either one is fine.
How's it going?
It's going good. It's going good. As you can see, I'm streaming live from my bedroom.
Streaming live. This is telemedicine world. This is what we do these days.
What we do these days.
And make it work. Well, I'm excited. We have 1,200 amazing students joining us so far. I think there were close to 10,000 registered. So we'll see how many want to come and hang out with us to talk about pediatric cardiology. Yeah. An amazing specialty touching so many lives. How did you first find out about pediatric cardiology and become interested in doing it?
So my first time really coming and interacting with it was in medical school. And I was not when I first encountered pediatric cardiology, I did not think I would be a pediatric cardiologist. I knew I liked peds, but I didn't necessarily know the breadth of pediatric cardiology. So, but med school was the first time I sort of started to figure out that it was a little bit more about the specialty.
Were you a peds all the way kind of med student?
I was pretty sure I'd be peds, but not necessarily for sure. I was going in thinking maybe OB-GYN and maybe peds. I was in between both of those. Yeah. I figured I'd probably be peds. Just from early, I've had a lot of interactions with kids. My mom owns a preschool, and I taught there when I was in high school, and have always just really, I just get along with kids really well and interact with. I just think they're really fun, and have always loved sort of being in that world. So I had kind of thought I would be it, but confirmed it in med school.
Yeah. Now, a lot of future pediatricians love the kids, and they don't realize that the other patient in the room can be just as challenging, or if not more so. Talk about the relationship with parents and how you have good relationships with them to do the best for your patients.
Yeah, so when I just talked about the my mom's preschool, so that was another thing I really liked. I liked being able to sort of interact with that sort of dynamic, the parent-child dynamic. I really think that parents in peds, parents are a little more likely to do what the pediatrician says, because it's almost like if it's coming down to our kids, we're more likely to follow through with things that need to be done for our kids versus ourselves. And so I just saw that a lot of times pediatricians had a little bit more sort of sway in getting their patients to kind of follow through with certain things, because we as parents are going to do anything for our kids. And it's also just a lot of, I don't know, I find a lot of joy now. I don't necessarily knew this in med school, but I find a lot of joy now in having a relatable conversation with a parent and kind of alleviating some fears, or educating them on something that they're, they don't quite understand, and just giving them also the ability to like be very relatable, and some of the things they're struggling with, or just say like, oh, I do the same thing with my kids, and like, and like all of those moments are very, it's great to be able to have them know that you're knowledgeable about something, but also have them see you as like a fellow parent and understand that like they just can relate to you a little bit better. So, and I obviously didn't have that when I was in med school because I didn't have kids. And a lot of times I used to get like a little frustrated when parents would actually request pediatricians or pediatric residents who had kids. And I used to get a little like, well, that's not fair. I understand. But then now that I'm a parent, I get it. I get it. Being a pediatrician and having a pediatrician who is a parent at the same time it does add an additional layer that makes it a little easier to relate to. So,
yeah, I think that's against Department of Labor laws, is to request or require that you have a child to match into a specialty.
Yes, you don't have to have a child. You don't have to.
Talk about, obviously right now we're in the middle of a pandemic that we got some good news finally today with the Pfizer trial. So hopefully that looks good in a couple weeks when they have some more data. Talk about from your end as a pediatric cardiologist, all of the news seemed to be that kids weren't affected, but now we're seeing some potential other things, especially potentially cardiac related. Talk about how COVID has changed your practice and some of the things that you have to look for now because of COVID.
Yeah, I mean, this is going to be the new Wild West now, right? We're talking about the MISC complications, and even kids who don't have MISC. So MISC, for anybody who doesn't know, is multi-inflammatory. What is it? Systemic something. I can't remember all the wording.
I'm googling it.
It's to Kawasaki, like what we see in Kawasaki's, which is a inflammatory disease that we see that gets triggered usually after a viral infection, and
it's multi-system inflammatory syndrome in children.
Yes, exactly. And so this is. I've talked about this with a few people. It's interesting because I don't feel like we've had something in our time where data is constantly evolving, and we're going to figure out how we're going to end up treating this. In my lifetime, at least as a pediatrician, and this is definitely going to be one of those things where, where I think when we first were doing it, we were thinking, is this Kawasaki's? You treat with IVIG, and now I go, but it's a completely different beast now. And then there's been a lot of talk about if a kid has even had COVID, how long can they return to play? Do they need to be seen by a cardiologist? The AAP has been, I'm pretty sure that they came out to say that like every kid needs to be seen by a cardiologist who has COVID, which is, a little bit crazy to think that could be. But Jack, Journal of American College of Cardiology, kind of came out with some guidelines about actual diagnose, especially athletes, and how to sort of go through that algorithm. So I think it's going to be really. It's going to be ever evolving. Obviously, I think we definitely will have a role in it. And it'll be interesting to see how the guidelines play out. I haven't necessarily had it in my practice at this point because I'm in the Bay Area and we're very still locked down. I mean, most of the schools in our area are not, they're not really back in. So competitive sports is really not much of a thing right now. So I haven't had to encounter it yet much in my practice, but we're set to start going back in January. So I foresee that that's going to start being something that comes across my clinic more often.
Yeah. It's one of those things, right? It's not really a silver lining, but it's just an interesting thing that comes out of a bad situation where we go through medical school and we learn about everything that happened in the past, and we know how to treat things and how to evaluate things because of what happened in the past. And now we're living through it, and it's just really cool. It's crappy, but it's cool from a medical standpoint.
Oh yeah, it's totally, I mean, it's been very interesting to watch us in real time readjust, especially, I mean, obviously not much in the peds world, but in the adult world, just adjust like, okay, this works, this does not work, this works, this doesn't. And now we've in real time watched this whole concoction of how we treat it, and people's, mortality rates are going down and things are getting better. So it is really, I think it's a very, and I hate to, this is not to downplay, but in terms of just being purely cerebral about it and medical terms, this is something we've never seen. And it's been very, very fascinating to watch how quickly we've advanced our therapies to make improved outcomes in a very rapid way. And even with the vaccine, like you talked about, to see how quickly it's come out, and to see, I saw an interview with Dr. Fauci today, just for him to say that even the way that they've done this vaccine, which is a little bit different than they've done it in other ways, and how effective it preliminarily looks right now, actually holds a lot of promise for future vaccines. And so it's an interesting time to be in medicine for sure. Yeah. No, I mean, it's a stressful time, and I'm lucky that I completely recognize my privilege and that I'm not in the trenches in the hospital, and so I get to think about it that way, where other people are just swarmed and and just getting by and are very burnt out. So I do want to make sure that I'm say that it's a ever changing and interesting time to be a doctor, but it's also very stressful for our colleagues that are going through just a lot right now. So,
yeah. Before we jump into the slide and talk about your journey and a case or so, what are some of the biggest myths or misconceptions around pediatric cardiology that the pre-meds watching this maybe have?
So a couple of them are that it is really, really scary. I will say that, yes, we do deal with some scary things, or scary or sad or depressing. And I will say that most of the time it's not at all, actually. It's really, I would say the majority of my clinic days are spent telling kids that they're fine and being able to reassure parents and do a lot of teaching. And even in the cases that are challenging or, kids are sick, there's a lot of goodness in it. It's not actually, the majority of it is not sad or scary. So that's one of those things. You say, because you go outside into some person and you say, like, I'm a pediatric cardiologist, and they're like, oh, get that face. Like, no, it's really
yeah.
Like, that sounds awful. That sounds really scary. I'm like, yeah, I get it, but it is not like a super somber thing. And then the second one is that that pediatric cardiology and adult cardiology are kind of the same, and they are not at all the same.
You don't deal with coronary artery disease and MIs all the time in kids?
The pathology between pediatric cardiology and adult cardiology it could not be more different. And so, when people ask, like, well, how did you decide between going into peds or adult cardiology? And I'm like, I didn't even ever think about going to adult cardiology. It's a very different way to get there, and it's a very different world and the things that we treat. And I always like to joke that adult cardiologists could never handle. They get freaked out by pediatric cardiology. I just see it when I have to see an adult cardiologist read a peds EKG. They're like, sinus tachycardia, T-wave inversions. I'm like, that's normal for an 11-year-old.
Yeah.
So yeah, those are kind of the two biggest myths I hear.
So one of them, the reaction that you get of like, oh, like, isn't that sad? And oh, like, that's so somber, right? As you said, that usually comes along with this assumption that every kid that a pediatric cardiologist sees, or whatever specialty, is the most acute, the worst situation that you can find, right? It had the worst congenital defects that anyone can see. That's every patient. And we've had a lot of physicians talk about, right, for you to love your specialty, you have to love the bread and butter. What is bread and butter in pediatric cardiology? So
pediatric cardiology, and I will preface that by saying outpatient general pediatric cardiology, because they're obviously different. A lot of specialties within in the field, but the bread and butter is murmurs, chest pain, dizziness or passing out, family history of some sort of condition, whether that's cardiomyopathy or some other type of thing. And then congenital heart disease. So I would say that, but probably the biggest things I see, like, are always somewhere on my schedule, are a murmur, a chest pain, and a kid who passes out. Those are probably like my three bread and butter that tend to be innocent things that I see.
Cool. All right. Well, I'm excited to jump into your slides and your presentation here. You ready to go with that?
I'm ready. All right. So we did a good job of starting things out, but what is pediatric cardiology? So pediatric cardiology is the people who practice, who are physicians who practice pediatric care of hearts. And we see kids from fetuses to young adults. And one of the big things about pediatric cardiologists that I think is really sort of key to us as a specialty is that we are experts in the field of congenital heart disease. And congenital heart disease is basically meaning that kid, their heart didn't form correctly. And so, and I say that because this is sort of a defining feature specifically from adult cardiology, just like we talked about before. There are some adult cardiologists who do congenital heart disease, specifically adult congenital cardiologists, but we are the lion's share of the people who take care of patients with congenital heart disease. And I am biased, but I think it's the coolest specialty. So how do you get here? Obviously, you need an undergraduate degree of 4-ish years. Personally, for me, I did 4.5 years, and I went to Arizona State University in Phoenix and graduated with a biochemistry degree from there. 4.5 because I studied abroad in Australia for 6 months, which was a very smart decision, and it kind of threw me off so that I couldn't take, there was like Biochem 1 and Biochem 2 had to be sequential, so I ended up having to do a little bit of extra time to do that.
I don't think I remembered that you went there. That was my dream school growing up, because I grew up in Southern California playing baseball, and I'm like, I'm gonna go play baseball at ASU. That was my goal.
Go Devils! Always will. Bleed maroon and gold. And so then medical school, and I personally went to the University of Chicago, Pritzker School of Medicine, south side of Chicago for medical school. And then, so the next step would be pediatric residency. So there is 2 paths, pediatric cardiology. The most the most common one is a pediatric residency. So you match into pediatrics, and that one is 3 years, and then followed by a pediatric cardiology fellowship. When I was applying, we had to apply our 2nd year for pediatric cardiology fellowship in our pediatrics residency. I think now, if it hasn't already, it's going to be moving into the 3rd year, which is a little bit nicer because it gives people a little bit more time to figure out if they really want to do it. When it's second year, it's a little more, you have to make it a little bit more rapidly. For me, I knew after my first month in residency that I wanted to do pediatric cardiology fellowship. So I was lucky with that. But I trained at Stanford for pediatric residency and pediatric cardiology fellowship. Like I mentioned earlier, I did not know I wanted to do pediatric cardiology in medical school. When I went to University of Chicago, they did not have a very robust pediatric cardiology program, and they did have a surgeon and a small program, but patients tended not to do very well after surgery in the really complex kids. And to me, it just was like, if this is the field, I'm not really into it. And then when I got to pediatric residency at Stanford, that was pretty much the exact opposite. It's one of the strongest pediatric cardiology programs in the nation. They have really, really incredible surgeons and ICU and, cath lab and everything across the board. And so when I had actually gotten into residency and saw the breadth of the specialty, I was enamored, like completely enamored with it. I had sort of flirted with the idea of surgery in medical school. And what I liked a lot about pediatric cardiology, it was that it was very sort of succinct. We have a problem. We have ways to look at it with, EKGs and echocardiograms or a cath or an MRI, we had the ability to diagnose things. And it's very surgically minded, especially for congenital heart defects. You have to work with surgeons. You're thinking through the pathophysiology. You're thinking through the surgical process of certain things. And so I really liked those things about the field. And pediatric cardiologists tend to all it's kind of funny. I think, we always make fun of like different fields for having certain things, personality characteristics that are alike. And I just sort of fell into the personality characteristics of most pediatric cardiologists, a little bit more sort of cut to the chase, no BS, sort of like get it done type of mentality, which is a lot of what pediatric cardiologists are like. And then, like I mentioned earlier, there are definite ways to further subspecialize in pediatric cardiology. Like I mentioned, there's pediatric cardiac ICU, there is pediatric interventional cardiology, there's pediatric electrophysiology, heart failure transplant, pulmonary hypertension, lipidology. There are multiple different avenues now of things that you can practice within the field. So the world is your oyster.
Talk about the difference. I think a lot of students are confused between residency and fellowship. And why do you need extra fellowship if you're doing cardiology rotations during your residency? What's the goal of fellowship?
So that's great. You don't learn anything that you need to know as a pediatric cardiologist and pediatric resident.
You learn how not to kill patients.
Yes. So this is very different than adult cardiology. I think that in adults, and this really just because this goes to the percentage of disease that you see in patients in different age groups, right? So congenital heart disease is the biggest congenital defect. Like patients with that we take care of the most. Congenital heart disease is the highest amount of congenital defects that we see that are seen, but it is like 5% or less of kids that are born every year who have this. So it's a very small percentage of patients who actually have cardiac disease in the peds world, whereas in the adult world, cardiac disease is the number one killer of men and women, like by a substantial degree compared to other things. So as an internal medicine or family medicine or any path to how you get to adult cardiology, you're seeing the pathology of cardiac disease all the time in your training. It's not the same in pediatrics. We don't see we don't have the same burden of heart disease in our field. And so a lot of the things we learn as a resident are it's very basic. It's very sort of in a way to kind of get you to get a pretty surface level understanding of what's going on. And I will say that in fellowship, I had to unlearn like everything I learned in pediatric residency about cardiology, because it's really about fundamental building blocks of pathophysiology, of embryology, of, we didn't learn to read EKGs in residency. We didn't learn to read echocardiograms. We didn't learn, how to read intracardiac electrophysiologic signals like you see at the EP lab. There's such a huge amount of things you could never learn in pediatric residency that requires a 3-year fellowship.
Okay.
That makes sense.
Cool. Yep.
So who am I? Oh, I just kind of told you guys everything. So I go by, just so people don't know, clinically, I am Dr. Renee Rodriguez. I kept my maiden name when I got all of my licensure and everything, and just haven't changed it I am actually legally Renee Paro, and so I use that in other terms. And people always ask, my organization that I work for lets me call myself whatever I want. And so I go by Dr. Rodriguez at work because my husband is also a physician. He's Dr. Paro. He works in the same organization as I do. So that's why we've split it. And it's really important to me because I'm the first generation person in my family to become a physician. And I'm very proud Latina. So I've kept my name for that reason. But anyway, like I mentioned, University of Chicago, Stanford, I was a chief fellow at the end of my fellowship for the year, and I graduated in 2016, and now I practice fully outpatient, part-time pediatric cardiology at the Palo Alto Medical Foundation in Dublin, California, in the Bay Area since 2016. So I've been in practice for 4 years, which is nuts to me. I can't believe it's been 4 years. And so my practice mix is that I do general pediatric cardiology, just like I mentioned, which is taking care of kids who have congenital heart defects. I also screen for familiar heart disease, and then we, just like I talked about, and concern for disease secondary to specific symptoms, things like a heart murmur, things like chest pain, things like shortness of breath with exercise, passing out, all of those things. I see those things. I also take on a bend of preventative cardiology. So just like I mentioned before, I think it's really important. I am a lover of the heart in all ways, and to not acknowledge that the most morbidity and mortality of heart disease is in adulthood. I think there's an onus on me as a pediatric cardiologist to try to help improve that. And we know that the leading reason why people have heart disease is because it's acquired. It's through decades of not taking care of themselves, and predominantly due to lifestyle. So I have a preventative cardiology clinic where I have kids who I see who have obesity, high cholesterol, prediabetes, high blood pressure, and I really take on that clinic to start to teach kids early how to live a lifestyle that is healthy for their heart from the beginning, and to hopefully change the trajectory of their course for the future so that they don't go on to acquire adult onset heart disease. I also do fetal echocardiography. So that's ultrasound of a fetal heart. So I screen little fetuses who come in for multiple different indications. One of them obviously is if on a screening ultrasound around 20 weeks, there's noted congenital heart disease, they would come to see me. But there are also many sort of primary reasons why people just come to see no matter what. Patients who have who are conceived via IVF need to have a fetal echo. People who have diabetes who are requiring women who have diabetes who are requiring insulin. If a woman has lupus or Sjogren's, they have to come see me. So I take this on. I did a little specific additional during my third year of pediatric cardiology fellowship. I focused on fetal echo to be able to do that in my practice. And like I mentioned earlier, I was interested in OB, and this has been a fun way to actually continue to be in the OB world by getting to do fetal echo and interact with those patients.
Nice.
So I think this is a pretty funny slide. I love
the awkward Yeti.
He's so good. And I love the heart. He's so just
chasing the butterfly always.
Yeah, exactly. And that's totally me. Like I relate to that in a lot of ways. All right. So, I have a case, but I always like to sort of talk about cardiac anatomy. And I've put this in a couple of my lectures before because I think it's really important to understand the heart can be a little bit complicated. I tell this to a lot of med students who message me all the time who are like first and second year med students, and they're just like, the heart is so complicated. I don't understand it. Like I thought I wanted to be a cardiologist, but I really don't like this right now. And I always tell all of them, like, you can verify this with John, my husband. When I did cardiac physiology, I said to him, I swear on my life, I will never be a cardiologist. This is terrible. And look at me now. So things are different from learning in a book to getting to the bedside. But I'll kind of go through how I like to describe the heart to my patients because I think it's really helpful to have people get a context. So I like to use my analogy of the heart as a house. So the heart has two upstairs rooms, which are your atria, your blood collecting rooms, and they have two downstairs rooms, or the ventricles, which are the blood pumping chambers.
These are the fancy people houses. They have upstairs and downstairs.
Downstairs, yeah. And they also have doors between the upstairs and downstairs, which doesn't make sense, but just go with it because that's how I like to explain it. And then there's your two, so those are your four chambers. Then you have your they have two sets of doors. So there are your doors between your upstairs and downstairs rooms. So your atrioventricular valves, named because you have your atrium and your ventricle. So the tricuspid and the mitral valves are the atrioventricular valves. And then you have your downstairs to outside rooms, which are your semilunar valves. And those are your pulmonary valve and your aortic valve. And those connect to things leading outside of the heart. There are then two walls in the heart, your atrial septum, which is the wall between the top two chambers, and the ventricular septum, which is the wall between the bottom two chambers. So I think it's helpful to kind of think of things, and I personally like to think of things in that kind of frame of reference, and it has always helped me a little bit.
Yeah, I don't think I've ever heard that analogy in that way. That's definitely...
because it's a Renee. I coined it.
It's amazing.
It's amazing. I've never been taught it. I just thought of it myself.
Maybe you should have been an architect as well.
No, you don't. You would have to be architecting your house. I don't even think that's a word. I just made it a word. So I think that, I want to talk a little bit about auscultation because it really is one of our most important tools. And this is a question I've had asked for me. A lot of people, like if I've been able to sort of convert to telemedicine. And this is a reason why I haven't been able to convert as much to telemedicine as other fields may have been able to, because the physical exam in pediatric cardiology is paramount to our evaluation. And the case I'm going to share is actually happened right at the beginning of when we started to go into shelter in place, which the Bay Area was the first place in the country who did around COVID. And so the patient I'm going to talk about at the end actually was a kid that I had to navigate during that time, and I'm so happy I saw him in clinic, and you'll see why. Anyway. So the stethoscope is an extraordinarily important tool for us. In the cardiac exam, we have a specific places that we listen to things. So you want to think about where you're listening to things. So we have, we look to the right upper sternal border, left upper sternal border, left lower sternal border, and then the apex. And at each of those locations, you're listening for different each one of those is over a different area of the heart, specifically the valves. And so there's a lot of different mnemonics, but my favorite is all physicians take money. APTM. So in the right upper sternal border, you're listening for this is more where you're going to prominently hear your aortic valve. In the left upper sternal border is more, you're going to more prominently hear your pulmonic valve. Left lower is more the tricuspid, and the apex is more of the mitral. And when you're doing your evaluation, it's more than just listening. There's a lot of, and you'll learn this when you get into medical school, but it's, there's actual visualization, there's palpation, there's auscultation, there's multiple different things. We also listen in different areas like the neck. So hearing up here, this is where the carotids, and you may hear things up here. Listen, especially in kids, to the back. So you can hear a lot of things that if it's radiating to the back is really important, or the axilla. And those are all places we listen to depending on what we're hearing. Let me see. So when we're listening for auscultating, what are we actually listening to? So everybody can know when you're hearing a heart sound, you're hearing the lub-dub, lub-dub, lub-dub. So what is the lub-dub? So we in cardiology refer to that as S1 and S2. And so the lub-dub is actually closure of one set. So there's two sets of valves, so it's closure of each set. So closure, the S1 is closure of the tricuspid and mitral valves, and S2 is closure of the aortic and pulmonary valves. What's important about S2 actually is, so in S2 you have something called a physiologic split of your S2. So it's lub, dub, lub, dub, lub, dub, lub, dub, lub, dub. Lub-dub. So anyway, so that's just something to note with these two, because as you inspire and exhale, there's some changes in the intrathoracic cavity that causes the valve sounds split a little bit, and it's actually really important for certain defects to hear that split. If you don't, it could mean that things are wrong. If the split just stays split, never comes together, that could mean that things are wrong. So there's a lot. It's a very complicated. Anything that's additional to the lub-dub sound is an extra heart sound. So a murmur is essentially a whooshing sound that we can hear between the S1 and S2. So I like to talk about it with people where you use like lub-step, lub-step, lub-step. So it's kind of like a little sound in between, and that's a terrible rendition of what it is, but that's kind of just what it is.
We need to get John to mix a heart sounds record album for you. I know his skills, his talents.
There's also things called gallops, and gallops are just sort of an extra little kick that we can sometimes hear in the middle of the S1 and the S2. There are things called rubs. Rubs actually really sound like tires, kind of like we can hear it's just like tire noises, that like something's rubbing together. And rubs usually tend to happen mostly around surgeries or like pericarditis or other kind of stuff. And then there's clicks. And clicks are when the valve specifically usually, actually all of them can make a click, but a lot of times if there's something going on with the aortic valve or the mitral valve, and there you can hear an extra little additional click sound. I always get people who ask me questions, how do I do this better? How do I like learn heart sounds, all this stuff? And my advice is always the same. Listen to as many hearts as you possibly can. Yeah. Because, and I did this in residency when every patient, even when I probably didn't even need to examine them, I examined every heart, because the more hearts you hear, the more you learn what normal is, and you get a sense of what things are supposed to sound like. then you can start to pick up abnormal. So you're never going to be able to pick up abnormal if you don't know what normal is. And in kids especially, their heart rates are very fast. And so learning how to be able to discern the sounds of a fast beating heart is really important. So just listening to a lot of hearts is my biggest piece of advice.
Quick question for you. Students right now, they're very excited about going out and buying their first stethoscope. Now, obviously, the Littman Cardiology 3 whatever stethoscope is the one that everybody thinks you have to have.
Yeah.
When I was in medical school, the cardiologist that taught us said it's what's between your ears that's most important. What are your thoughts on buying a super expensive stethoscope versus one that's much cheaper?
I wholeheartedly agree, and I will tell a story to the students that you also think will be very funny, Ryan. Like, I actually did not own my own stethoscope for my entire pediatric cardiology fellowship. Because number one, I had two, and they both got stolen. They got swiped, and there's always a stethoscope. Anywhere you go, someone has one, or there's a stethoscope at the bedside. There's always a stethoscope available somewhere. And so then I just never had a stethoscope. And people thought it was hilarious that I was a cardiologist who didn't have a stethoscope, but there was always a stethoscope to find. So that my piece of advice is, yes, exactly. So much of it is actually having, there may be small intricacies that make one better than the other, but the majority of it is getting a good exam, especially in kids, like getting them not crying, being able to hear things, being able to get them to hear the heart sounds over their like in between their breaths. It's really so much more important about, just like you said, your brain and having knowledge about what's actually happening. That's more important than the stethoscope. So get what's on sale. You don't have to get anything super fancy, or you can just be like me and just bum it off of other people.
Nice.
Everybody always has a stethoscope somewhere.
Yep.
So specifically for murmurs, I think because it's easier, I don't want to go over to people's head too much. So murmurs, like we talked about, we grade murmurs, and this is actually systolic. There's two kinds of murmurs, and I don't know if I wrote on the next one, but there's two kinds of murmurs that we have, which is a systolic murmur, and that's between S1 and S2, and a diastolic murmur, which is between S2 and S1. A diastolic murmur, this is like seared into your brain. A diastolic murmur is never normal, ever. So that is always going to be a pathologic murmur. But a systolic murmur, which is by far and away the majority of the murmurs that people have, can be innocent. And in kids, they are innocent until proven guilty. So I always like to tell parents that pretty much if we had a stethoscope on every kid throughout their lifetime as they grew up, all of them would have a murmur at some point. It's really we're just hearing flow through the heart. Why some people we hear it in certain times and others not, I don't really know, but it doesn't necessarily mean something is wrong. So we grade them as systolic murmurs by 1 through 6 scale. So grade 1 is barely audible. And a lot of these ones I get, some pediatricians can hear some very soft murmurs. Pediatricians are the best murmur finders on the planet. Like a lot of them, I'm like, dude, I could barely hear that. Like, how did you hear that? So anyway, it's barely audible. Grade 2 is audible but soft, so you're not really guessing as much. Grade 3 is moderately loud with no thrill. So we talked a little bit about listening first. We also talked about palpation, right? I said or palpation. So when you're doing an exam, you also want to place your hand to feel if you feel anything. So a thrill is actually where if you place your hand on the chest, you start to feel a little bit of vibrations on your palm. So that's a thrill. So a grade 3 is that it's loud. It's definitely discernible, but there's no thrill. Grade 4 is loud with a thrill. Grade 5 is audible with the scope that's barely off the chest. So you test it by you have your stethoscope and you sort of tilt it to the side. And if you can tilt it to the side of your chest and still hear it, then that's a grade 5. And then a 6 is if you can lift your stethoscope off of the chest and you can still hear the murmur barely off the chest, and that's a grade 6. And that's how we standardize our grading of murmurs.
Do you think with the advent of electronic stethoscopes that at some point, like an EKG machine can give us some readings, we'll be able to place an electronic stethoscope on someone and it'll tell us murmurs?
Well, there is that technology right now. I think what is called Echo Health. They have that technology. Actually, something that my group, we had actually a meeting with them to talk about whether or not we should look into using that for telehealth, having a nurse go to the house and take a listen. I think the technology is getting there. I think it is much more sophisticated for adults whose heart rates are a lot lower, and you could probably make out a lot of these things a little more easily. It's much easier to hear a murmur in a person or a click or a rub or anything else, somebody whose heart rate is 75, much less easy to do in a patient whose heart rate is 135 beats a minute. So I think that the technology is getting there. I don't think it's there yet, but things are rapidly moving. So I could see it. Moving in that direction for sure. And the EKG reading, the EKG things of it is actually really cool technology as well. So it's a fun time to be a cardiologist. There's a lot coming out. So like I mentioned, so innocent murmurs, usually grade 2 or less, and found in the left mid-sternal, lower sternal border. Like I mentioned, normal S2, right? So I talked about the physiologically split S2. If the S2 is prominently split, or we call it, God, why am I blanking on it? The S2 never comes together, then we know that there could be a problem. And if there's a singular S2 without any splitting of it, we think that that's also a problem. No clicks, because a click could, like I mentioned, be more indicative of some sort of a valve problem. And then otherwise normal exam, they have good pulses. Things that make it a little more likely to be pathologic is that it's grade 3 or higher. It's harsh. It goes all the way through S1 and S2. I don't know why I wrote louder at the left upper sternal border for some reason, but because those locations, I guess, are a little bit less common than the lower sternal borders. And then, like I mentioned, an abnormal S2 or other another physical exam abnormalities. So that's my talk on the auscultation piece. And now I have the case study if you want to move.
Cool. Let's do it.
So this is a kid, 12-year-old healthy male who I will give it to you just like I got it. So I got a referral in my M basket. And
actually, hold on. Let me bring some students on, and you can ask them some questions. So if you want to come on, raise your hand to speak. All right, go ahead. And they'll pop on as they come on.
Okay, so 12-year-olds, healthy male. He was referred to me with a murmur. So kind of little backstory before I talk to the other people. So this was happening, like I mentioned, right during the week that shelter in place happened. So I had to be triaging which patients needed to come into my clinic that week and which one.
When you're coming on, go ahead and mute yourself.
So this patient came through my referral, and the story was that he was seen in urgent care 5 days prior, and he was diagnosed with strep throat. And at that urgent care visit, they heard a murmur. So the urgent care doctor put in a referral because he had a murmur at that visit. He had a normal medical history with no other significant problems. He had no cardiac symptoms whatsoever, no chest pain, no shortness of breath, no dizziness, no syncope, none of this at rest, none of this with exercise, and he's also a competitive football player. And there was no significant family history. So does anybody have any thoughts about this?
Who's here with us? Share your thoughts. Emmanuel, Anna, Amira.
I don't have any thoughts. I'm a coach, so I know that sometimes kids can get sick. I'd be interested to see what his, strep throat was like.
Very good. Very good to point out, because you're a coach and kids get sick. So I tried to triage this patient to say that this patient didn't need to be seen by me for a few months because he was fine. So when we, like I mentioned before, right, murmurs are more likely to be innocent than anything else. Murmurs in this age group specifically, without any other symptoms and having hadn't heard it before, tend to be innocent, especially during a sick visit, right? So this kid came in and he had strep throat, so he likely was a little dehydrated because he wasn't drinking as well. He maybe was like maybe had a low grade fever, and all of those things can actually make murmurs more prominent. So when I read this consultation, and he had, when I got this from this consult, I said, this is likely an innocent flow murmur that's just happening from his illness, and this can be something that waits until we are out of a little bit of this really urgent pandemic stretch for like a month or two. The one thing that made me actually see this patient is this mom is a nurse, and she was worried about something specifically that goes with strep throat. And this is a little bit more of an advanced question, but does anybody know of any heart conditions that can be a result of strep throat?
I think rheumatic fever, potentially.
Perfect. Very good. So this patient's mom is a nurse, and she heard a murmur. She got diagnosed with strep throat. And so she was very, very concerned about rheumatic fever. I felt confident that he didn't have that because kids with rheumatic fever tend to be tachycardic. He wasn't super tachycardic, having other sort of cardiac signs, and he had no fever. Then when he was seen by them, he actually had no fever. It was just sore throat. So my thought was to still not see him because I was unlikely he had rheumatic fever, but mom was very concerned and very worried. And what I have learned as a pediatrician is that you always take parents seriously. And so I discussed with her that there was some risks right now, given the COVID pandemic. She really wanted to be seen. So I saw him that week. So as a pediatric cardiologist in my practice, I always get the first thing before I ever even see the patient. Actually, I see their EKG, because when I have a pediatric cardiac patient coming in, my medical assistant goes in, she gets an EKG. So I have sort of the history that I've read from the chart on the electronic medical chart, anything I've talked to with the person who sent the patient to me, and then I have my EKG. So this was the next thing I got in the step of care. I should have blocked out the actual thing because I have the read up there what it is. But has anybody worked with EKGs? Gosh, if you guys are like so much more advanced than I was.
So I haven't seen an EKG in like 10 years. I was an exercise science undergrad, but that T wave was kind of high. But I could be wrong. EKGs weren't my strong suit.
No, so this is a challenge, because honestly, for pediatric cardiology, another nuance is learning that pediatric EKGs change as kids grow. And especially in young athletic males, a lot of time these sort of mid-precordial lead things that we see can look like there's something major going on. So these are a little prominent. If I went back to read it now, knowing the history of knowing exactly what this kid had, may have changed it, but this can be seen and can be totally normal. So it can indicate left ventricular hypertrophy. These T waves are a little bit generous, but that can be seen on a normal EKG. He does have a little bit of a borderline prolonged QT interval. A QT interval is basically the beginning of this QRS to the end of this T wave. And we sort of do a little mathematical equation to get the actual number. But in boys, it should be 440 milliseconds or less, and his is 470. So he definitely goes into the prolonged QT area. But notably, things to look at on here is, so it's a normal sinus rhythm, so it's coming from a right place. He looks like he may have signs of ventricular hypertrophy, but it's something that I see on a lot of EKGs of totally normal 11-year-olds who are athletic. T-Way's maybe a little bit generous, but he doesn't have other signs of something called strain or what is kind of like the heart's having difficulty squeezing. And that's what I know about him before we go in. So generally normal EKG, a murmur that probably could just be because he was sick. So then my physical exam. So blood pressure for him, pretty normal, a little bit high, but a lot of times when kids are coming to see me, they're nervous. His heart rate was normal in the 60s. His oxygen saturation was normal. So from a cardiac perspective, it was quiet and he had no thrill or heave. And when he didn't have a displaced apical impulse. What that is so we talked about the apical areas where that's where sort of the heart is closest to the chest wall. It was not displaced, meaning it wasn't to the left or to the right. It was sort of in the right place it was supposed to be. He had a regular rate, and this is something that I always do because people always have on their cardiac, when people write it down, they always say regular rate and rhythm. I never write in rhythm because you cannot tell if somebody is in a normal rhythm by listening to them. You have to be able to verify that with an EKG. So I always say regular rate, and that's it, and I leave it there. He had a normal S1 with a physiologically split S2. But this is where we get to something is fishy. So his murmur was a grade 2 to 3 mid-systolic crescendo medium pitch murmur in the left upper sternal border. So it was very much not a normal murmur. So this murmur was sort of like you didn't hear it in the beginning, and then all of a sudden you heard it in advance. And a crescendo murmur, you kind of can think about it, it kind of goes like this. So it gets louder as it's moving into S2. And so one of the things we talk about crescendo murmur sometimes is it actually can overpower S2 where you don't even hear it. You could still hear S2 on his. So the second I put my stethoscope on his chest, which is why this is so important, auscultation and the exam is so important, I immediately knew something was not right on this kid. And there was another thing that I did based off of thinking I knew what was going on, where I had him squat down and stand up. So when he squatted down and then stood up, it actually got louder. So I had a big suspicion that something was going on from here. And if anybody gets this, I'm very impressed. What do you think I was thinking at this point? Anyone?
Come on. Nobody.
If you know this, I'm like, you should be a pediatric cardiologist.
You get your certificate now.
I guess
certified.
I'm just going to guess, but maybe that his murmur changed with exercise. But I don't know how.
Well, yeah. So it would change with exercise for sure. Is there anything you're thinking about from a pathologic perspective?
No.
That's okay. Let's do it. So the next thing I did was order an echocardiogram. So echocardiogram obviously is an ultrasound of the heart. And I want to kind of give you a frame of reference for what you're looking at here. So this is sort of the heart. This picture right here I'm going to show you is kind of the heart getting cut sort of in this direction. And this is what it looks like. So this is the right ventricle sort of in the upper part here. And then your left ventricle is sort of prominently here. And then your left atrium and your aortic valve. So this is your aortic valve, left atrium, so you see it. So I'm going to first give you a picture of a normal heart. Okay, so you see that. So this is mitral valve, aortic valve, ventricular septum there. So that's normal. This is the patient's heart. Do you guys see anything on there that looks strange? So patient, normal. What are your thoughts?
Play the patient's heart again.
So I'm not going to make you guys get, because this is hard. So if you notice here, so this is the ventricular septum. Look at how thin this is, right? Look at the patient's heart.
Yep.
See that thickness?
Yeah, I was going to say it looks like there's not as much tissue there. And then because it's like not as much, it almost looks like the ventricles are like beating out of rhythm. Like they're not beating like in the order that they're supposed to be beating.
Yeah, so what you're seeing though probably here, so you see how this valve, so this is the anterior leaflet of the mitral valve, and you see how it's kind of like smacking this a little bit?
Yeah.
It's there. And here you're not seeing that. Like the mitral valve is pretty far away from this. So you mentioned that this looks thin, and you're right, because this is too thick. This area right here is abnormal. So this is how thin it should be over here, and that is too thick. So here's another view for you guys to look at. And I didn't compare it with one that's normally, but this, you can kind of see it better. So that ventricular septum, the wall between the two ventricles, is too big. That is too thick. This area is also a little bit more prominent as well. So to cut to the chase about what this kid has, so he has hypertrophic cardiomyopathy. Another word is hypertrophic obstructive cardiomyopathy. And so this is the, you guys hear about kids who otherwise, the star athlete who passes out and dies on the middle of a basketball game. This is in America, the leading cause of sudden death in athletes, making up about 36% of sudden cardiac death in young people. So how it's autosomally dominantly inherited. So there's typically a pretty significant family history. And if you remember with this kid, he had zero family history. That's actually a really important thing to note in cardiology. The symptoms depend on the severity of disease. He was asymptomatic. And like I mentioned, so family history is typically key. And one of the physical exam findings, like I mentioned, that's really important about this is that the murmur quality changes from standing to squatting and squatting to standing. So it increases when you go from a squatting to a standing position, and it decreases when you go from a standing to a squatting position. And this has something to do with afterload. So, and that gets a little bit too much into the weeds with you guys, but it's changes inside of the heart and the pressure that you kind of create when you squat down that makes the actual murmur a little bit lower because you're having less sound of the flow going across that ventricular septum. So this kid, I diagnosed him with hypertrophic cardiomyopathy and sent genetic testing on him, which was ultimately negative. So he has no gene defect no identifiable gene defect for his disease. I screened his siblings. His parents were seen by cardiologists, all screened negative. So he had a sporadic mutation that we probably haven't been able to pick up yet, but that caused this. So now he's going to be seeing me twice a year because I'm going to have to watch his ventricular septum to see if he progresses and how fast he progresses. He can no longer play competitive sports, and that was a major blow that I had to deliver to him, his family. And this is because patients like this are at high risk of sudden cardiac death. He can still exercise and doesn't have to never do any of those things, but people who participate in competitive sports will tend to push themselves beyond their perceived inability to do something because they're trying to win for the team. And this is something that basically we've said they can't do. And for him, we start to talk about putting on medication for the amount of obstruction. So I'll kind of LVOT obstruction. So when we go back here, so if there is such a degree of LVOT obstruction, and this is right here. So we talked about the mitral valve slapped in sort of against the ventricular septum. If there is obstruction to blood flow that starts to happen right around here, that's significant because the wall is very thick, then we have to actually slow the heart rate down to improve that obstruction. So he's not currently obstructive yet, and so he's not on medication, but we'll need to go on that if he progresses more. And it's 6:02. I'm going over.
That's all right. How much more of the case study do you have? That's it?
Mm-hmm.
I have a question.
Yeah.
Yeah.
I've definitely seen, the cardiac thing. It's like almost amazing that some kids make it all the way to college and then have a cardiac event. But when we tell our kids to go get a physical, we recommend that they get an EKG just because, our staff has like a knowledge of and an experience of kids having this, cardiomyopathy. But like, what do doctors say? Because it's not required by like all physicals, but like you never know when somebody has like this type of, defect.
So that's a great question, and there is a lot of debate about pre-screening sports EKGs, and a lot of people point to doing this in our population based off of a lot of what's been done in Italy. So in Italy, they actually do require this prior to screening, and that's because their cause of sudden cardiac death is actually different than it is in America. So in Italy, it is something called arrhythmogenic right ventricular cardiomyopathy, and that's something that you can actually pick up easily on an EKG. So those patients, you can screen them who are asymptomatic and then find the disease. Just like I showed you on this patient, his EKG wasn't necessarily abnormal. There's a couple of things looking back that maybe I could call a little differently, but the majority of cardiologists who probably saw this, and if he didn't have a prolonged QT, would have maybe said, this is fine. So there's a lot of really doing all the EKGs, doing the amount of EKGs on patients to do screening, you wouldn't have the number of cardiologists to be able to read that many. And there may be a lot more false positives that could lead to a much greater utilization of resources to catch something that it makes it challenging. So it's a good question. It's something we talk about all the time in the pediatric world. It has not come down. There hasn't been recommendations to do that because the screening EKG is imperfect in many ways, if that makes sense.
Yep, definitely.
Awesome. Well, Dr. Rodriguez, thank you so much for your time sharing your case.
So Dr. Renee Paro on Instagram. If you guys don't know, I have my little thing. I'm a mom. We have a reconciling medicine podcast that Ryan cheerleaded me to doing. We also have a nonprofit called Dr. Vegetable too that you guys can check out too. It's our little baby.
Yes. Well, thank you so much for coming on and sharing your wisdom, sharing your specialty with everyone.
Thank you. This was great.